and I find them to be really effective and very helpful. So I'll just introduce myself. Rich, thanks for the introduction. We do go way back, 43 years about. And so my name is Clay, and as Rich mentioned, I am an emergency physician, and lots of people who are unmuted.
A reminder, please mute your microphones while Clay's talking. Then when you want to ask questions later, you can just click.
Yeah, a lot of background noise. Thank you for that. So yeah, I'm an emergency physician. I practice in South Lake Tahoe, California, and I work in a small sort of community emergency department. We're pretty busy. You know, we have quite a bit of volume here in terms of the tourist seasons, but it's still a very small community hospital, much like the Wallowa Hospital, and probably on the order of the size of LeGrand, I would assume, the emergency department and the hospital services. We are like you, we are a very popular tourist destination, and the pandemic has challenged us to sort of not only manage our own sort of community and our own healthcare services, but also to integrate the potential surge cases from the outside, and we've had to mitigate that on a number of levels, both at the hospital and in the community. As Rich mentioned, I have been deeply connected to Joseph and the Wallowa County for decades. My entire family has been there in some capacity since the 60s, basically, and it's a real honor to be able to come and speak and talk with you guys via this mechanism, the Josephy Center, which has just turned into such an amazing organization. So again, thank you for inviting me. I want to start by saying, is everybody familiar with the little the chat function down at the bottom of the screen? If you look down at the bottom of the screen, there's a little chat window, and in that chat window, while we're talking, I've found that the best approach to these types of events is kind of a Q&A, because there's just the questions that kind of stimulate conversation and discussion that have been really effective. So if you have any questions that you want to address, just type the chat box down below and we'll kind of get through them one by one. I find that to be a really effective mechanism. So I don't have like a prepared talk here, so I hope that the questions really get us rolling. I will give you a little bit of just for interest's sake. I mean, I think we're all hawkeyeing and just hanging on to the daily news, looking for what's happening in different locations and where's the next hotspot, and is our reopening and some of the other current events, including protests and people in the street and other events, is this resulting in little clusters around the country. And as you unfortunately are very privy to, it is happening in little sporadic outbreaks, which is expected. And unfortunately, Union County looks like they're going to see a little bit of a cluster there. In California, I have to say that we have been doing really well. The most recent data, there's definitely cases, and even here we have seen a number of cases. I work in the emergency room. Last night, I saw about 20 people in the emergency department, and I tested 8 of them for coronavirus with sort of suspicious symptoms, and we're starting to see actually more of that on a day-to-day basis in terms of people coming in with, respiratory symptoms and other infectious type symptoms that, certainly could be and probably are coronavirus. So there's no doubt that there's significant community transmission, probably virtually in every state, and in some states, you're starting to see new hotspots arise. I trained in Arizona, and unfortunately, all my colleagues down there at the big tertiary medical center are operating in a situation in which they have almost reached hospital capacity and intensive care unit capacity, and yet the community transmission is actually increasing on an exponential curve. So, in the midst of all this, what we all want to avoid is another, New York scenario, and some other places, New Orleans and Detroit and other areas where things got really out of control and the hospital systems became overwhelmed. So as we watch this with bated breath, we're all going to have to sort of, I guess, be agile and be willing to, kind of roll back and forth our I guess, lockdowns and stuff, as cases rise, and in certain areas. So, that's that. I don't see, is anybody asking any questions yet? Let me take a look at this.
I see one from
Yeah. Okay. Yeah. So this is good. These are the kinds of questions I hope that we can get to. We have an hour here. Is that correct?
Yep, you've got an hour.
Okay. So yeah, there's a lot of questions that are coming up at this phase in the game. One of the things that's been so difficult for all of us is that during all of this, we have been exposed to information overload, and the information is constantly changing and seemingly conflicting. And there seems to be a lot of information that's being redacted and changed and altered and reversed, including all the way to the CDC guidelines. And I think because of that experience, there's a lot of uncertainty, confusion, and even in some circumstances, conflict. The reality is that we're just all enrolled in this crazy experiment that none of us consented for, and the reality is we don't know a lot of answers to the questions that we would like to know, and so therefore they're going to be changing on a day-to-day basis. One of the questions that Melissa here, hi Melissa, offered up, the conflicting information regarding transmission by mist and droplets is the question, and I think that is actually one of the, it really causes a lot of confusion for people, because one of the most important things about understanding a virus or any sort of infectious pathogen is like, how is it transmitted? Because if we know how it's transmitted, then we can intervene in ways that would be effective at reducing transmission. And now with respiratory viruses like the SARS-CoV-2 virus, they are primarily transmitted via respiratory secretions of droplets. So that droplets are defined as sort of large respiratory secretions. When you cough out a whole bunch of, or sneeze, there's a lot of large droplets. And I think by mist, what Melissa's referring to here is what we call aerosols. And so people get very confused about the difference between airborne transmission and droplet transmission, because droplet transmission is a thing where these big droplets are going to come out of somebody's airway and they're going to drop to the ground via gravity before a distance of, say, 6 feet. So that's where the 6 foot number comes from. If you stay 6 feet away from someone, you're unlikely to be in contact with these larger droplets. Airborne and aerosols, on the other hand, are very, very micro, tiny droplets that actually float around in the air. And one of the things from this pandemic that's occurred is have been all these amazing visual fluid dynamic studies that have been coming out all over the news. And you've seen these videos of people coughing and infrared scanners and being able to actually look at the respiratory secretions that actually come out just when you're talking or singing or even breathing. And the question remains, is that a meaningful mechanism of transmission, the aerosols? So this gets really confusing and really subtle. There's a lot of assumptions. The bottom line on this, Melissa, to your point, is it droplets or is it airborne? The true answer to that is there's not a dichotomy. It's both. There are going to be situations in which there will be airborne transmission. And there's been a couple of examples of that. For example, there was a CDC article, the weekly morbidity and mortality report came out and actually discussed this event in Seattle. You may have heard about on the news early in the pandemic. There was a choir practice in Seattle where there was about 60 people that got together and they were singing. And when you're singing, the ability for the virus to transmit into the air, the aerosols, really has a lot to do with the amount of airflow that's coming from your airway. So if you're coughing, that's like 200 liters a minute. If you're just talking, I'm sorry, if you're coughing or sneezing, it's a lot of airflow, a lot of pressure. And if you're just talking quietly, there's much less so. But if you're singing, you're really projecting yourself, there's actually videos that show pretty significant aerosol transmission into the air. So there will be events in which there will be airborne transmission. There's no question about that. The question is, what is the what proportion of transmission is attributable to airborne? And it's probably very small. And the answer, and that's true of most respiratory virus, including influenza. Influenza can also be transmitted via microaerosols, but it doesn't seem to be a real important mechanism of transmission. Most cases are contracted via droplets, people coughing on each other, and then by surface contacts with surfaces that have been contaminated. This is why we probably the two most important take-home messages in terms of preventing viral transmission is going to be washing your hands. I just talk about the hands. Like, if you just really focus on your hands and know where they are, know what you're touching, don't touch your mouth, don't touch your face, you're going to interrupt transmission substantially. And then as far as the mask thing, that's another question maybe we can get into later. If you are sick and you are coughing and you are sneezing,
Josephy, brown bag.
Oh, good.
oh, sorry. If you are coughing or you are sneezing and you are infected, wearing a mask will absolutely reduce the transmission of those droplets. Okay, so that's kind of a long answer to a pretty complicated question. Just to summarize, there are droplets, which are larger respiratory particles, and there are aerosols, which are tiny microparticles that can float in the air for hours and hours and hours. Both of them are potential transmission mechanisms, but droplet transmission is going to be much more important, probably in terms of the overall pandemic. Now, this is basically comes down to, if I'm in an elevator and I'm sick and I'm infected and I cough into the elevator, a closed space, and then I get off the elevator and you come in, immediately after me, there will undoubtedly be respiratory aerosols in the air. And, I probably coughed all over the wall of the elevator, and you touched the button. I mean, there's a chance of you getting infected by touching the surface that I just coughed on, or possibly even getting in contact with some of the droplets that I just did immediately. However, if I cough in an elevator and you walk in there an hour later, it's very unlikely that there's going to be stuff floating around the air that's still transmittable. Those are aerosols. Just to sort of hammer the point down, this is kind of an interesting way of looking at this. The R naught, you probably have heard of the R naught. That's it's called the reproduction coefficient, and that's defined as how many people on average will one infected person transmit the infection to. And it's a measure of how easily transmittable a virus is, or an infectious pathogen can be. So with influenza, for example, the reproductive number is around 1.5. So everybody who has influenza is likely to infect, 1.5 people ish. It changes year to year depending on the virus. The SARS-CoV-2 virus, the COVID, is more of on the order of 2.5 to 3. So it could be up to twice as more infective and easily transmittable than influenza. And those are both, considered droplet viruses for the most part. Contrast that with measles. Measles is a known airborne pathogen. It is a known mechanism. Aerosols like mists, like Melissa points out, are a known mechanism of transmission of measles. And the R naught for measles, the reproductive number for measles, is like 18. Okay, so when you have a virus that is easily and effectively transmitted via airborne route or via these aerosols, then those are the kinds of viruses that sweep across communities like, wildfire. Not that this is not, but you see a little bit of a different transmission mechanism. So it seems like the majority of cases are going to be contracted via droplets and or surface contacts in close contact, but there will be situations that airborne mechanism is important. And that's important for us to recognize and not to quibble about the dichotomy between droplets and aerosols, because it's not one or the other. It's both. And so you want to be really conscientious about things like being in closed spaces where people are talking loudly, for example, and not having adequate ventilation, and also maintaining, a healthy distance from one another. As terrible as that is, that's one of the only true ways that we can mitigate the transmission of the virus. So that's a long answer. I'm pretty wordy. It looks like Mike is raising his hand there. Do you want to chime in here?
Yes, if I could. My wife and I are 70 plus. We're in our mid 70s, so we're concerned about this, very concerned. But it's very discouraging to think that we're in the beginning of this disease. And frankly, while we're saying there are no cases in Wallowa County, to me, it's going to be everywhere. So it becomes very discouraging to continue to try to isolate, to wear your mask and see life as usual going on. What are the chances? I guess that's not. Should I persist? I would just give it up and take my chances and get in contact with the disease and hope I don't cork off.
No. I cannot emphasize enough that we all have to persist. The thing is this is something, it's quite frustrating to look at the news and see a bit of it kind of feels like we've kind of moved on, like everyone started just throwing their hands in the air and said, okay, there's nothing we can do, so we're not going to do anything. That's not true. There's a lot that we can do. And you are right, the virus will travel everywhere, and it will circulate everywhere, and it will arrive in Wallowa County. And you will see areas of the country that get really hot, and you might actually see another New York. Hopefully not. That's what we're trying to avoid here. And I think we're much, much more prepared now than New York was. So it may not actually occur, but it's certainly a possibility. To your point, there are a lot of things that you can do, and rational things, and not just lock yourself in a closet. You can, like we said, just kind of maintain a healthy distance from people. If you're sick, certainly isolate, stay away from sick people. Really focus on your hand. I mean, I think it's perfectly reasonable to carry around a little, micro thing of hand sanitizer and just be crazy about it and sanitize your hands between. I always tell people, like, everything that you do, every activity that you do with your hands that touches of any surface, think of that as a discrete activity, and think about the before and the after. And so for me, like at work, I've been exposed to coronavirus many, many times now. I'm super careful. I wear PPE, but the thing in my mind, the thing I'm focusing on in my mind is my hands. And I try to do hand sanitizing before and after every discrete activity that I do, or every task that I do. And that, I think, is something that is usable for the public. And then you get into, and then distancing and just being, trying to stay a little bit away from people. I go to the grocery store, and when I'm in the grocery store, it's weird because we're pretty social creatures, biologically, and it's difficult to maintain distance where you see your friend in the grocery store and you want to go give them a hug, and it changes everything, but you can't do that. And holding doors for people. I always hold doors for everybody, particularly, elderly people or whatever. That's just what I do. And nowadays you got to hold the door, but you got to hide behind the door. You have to make that extra conscious move, step to make sure that you're just kind of staying away from people's airways. And I always emphasize that. Think about the airway. That's where the virus is coming from. So I would encourage you to be very, just conscientious, cautious, but not discouraged. Don't let what you're seeing out there discourage you, because we can get through this. I believe that we can get through this rationally and safely, until there's a vaccine. And I think we can do it a lot more rationally than we are now. I think that we could have, more movement, safe movement and socialization than we are having now. So keep it up. Just be super, vigilant about things. I think that we all have to maintain vigilance. That's the thing. The old saying where talent only gets you 95% of the way. stamina gets you the last 5%. You got it. It's going to be a long haul, and we have to be vigilant. And I would definitely encourage you just to, keep being safe, but live your life. Okay, so I'm going to check out a couple more. So next question was, how can we get more people in Wallowa County to social distance and wear masks? Yeah, it's interesting. It's interesting how this, I'm a doctor, I'm a scientist. I'm not a very political person. And it's very, very interesting sociologically for me to see how something so basically biologic and has become political, and so the question of masks is actually really intriguing to me because the science is equivocal. The science is not clear on masks. But the politics seem to be pretty clear on it. There are people that are very, very, let's say, zealots about masks. There are on both sides. There are people who refuse to wear them for whatever reasons. And then there are people that actually feel like, if you're not wearing masks, you're a murderer. And the truth is, I think it's somewhere in between. I think that there's a role for masks, and in Wallowa County specifically, I think the most important thing, I don't know the answer to this. I guess this is Stephen. How do we get more people? I mean, some people are just not really on board, and what's going to happen, and this is so sad, and I hate to say this, but what's going to happen is as this virus gets more widely spread out through the country, more of us are going to have a friend or a family member or an acquaintance who gets really sick and has a terrible outcome. And when it starts to become real for every individual is when they are going to start to think differently about this. And that's the natural history of these things. And this happens in other epidemics around the world too. So as far as like, say, a social or a community effort to try to get more people to wear masks, I think that the more of you that wear masks and make it normal, the more people will take it up later on. Like, say somebody's walking down the street, you're wearing your mask, she's wearing her mask, they're wearing their masks, the waitresses are wearing their masks, the store employees are wearing their masks, and then there's the guy who says, I ain't wearing my mask, but then eventually that person's, uncle's former roommate is going to get COVID and die, and then they're going to be like, wait, everybody else is wearing masks, maybe I should. So I think that there's a sociologic approach to this in terms of normalization of the mask. That in other countries that have epidemics routinely, like in Asia, they got no social barriers to wearing masks. It is completely appropriate and acceptable to wear a mask in these countries, even outside the epidemic time. So I think we need to, I don't want to bore you with my sort of diatribe about mask science, but I think we all need to be rational about it, not fight about it. And those of us and then those of us who are on board, just wear masks all the time. Rationally. Don't wear masks when you're exercising. Don't wear masks when you can social distance and you're outside. Wear masks when you go into closed areas. Wear masks in stores. Wear masks in restaurants. What have you. Go back to the airway. Like, where am I going to be in contact with these respiratory aerosols? And then wear a mask. And if you're sick, everybody who's sick, well, they should be home, right? But if you're coughing or sneezing and you have to go out, then that's the time to wear a mask. So I would say just wear more masks, make it normal. Don't get baited in by the fight. Okay, this is science, not ideology. And if you feel comfortable wearing masks, then go ahead and wear your masks, and eventually it'll be an uptick. After the United States is done with this pandemic, we will understand infectious disease epidemics better as a society, and we will be more willing to participate in the necessary steps to mitigate epidemic. Go over to Hong Kong and and ask the people in Hong Kong what they think about masks. You know what I mean? The whole concept of epidemics is going to change dramatically through this. So good luck with that. I was actually, I've talked to a couple people in the county, and I hear there's a little bit of reticence to wear masks in the county, and I just part of what's going on right now. Just keep doing what you think is right. If someone contracts COVID-19, how long do they test positive? Wow, that is such a fascinating question. There are many, many, many reports, including some of our own patients here, who have been testing positive for weeks, right? And you've probably heard that in the news, and that's a big news story. And that has been of some interest all the way back to the beginning of the pandemic in South Korea. They were the first to publish when they this thing about somebody tests negative and then they test positive, and then there's people that are positive for 21 days and even longer. What does it all mean? The test. Okay, let's just briefly. What is the COVID test? You stick a swab in your nose. You get some respiratory. You get some epithelial cells from the walls of your nasal sinus or the nasal cavity, and what they're trying to get is virus. Okay, and then you take the swab. You put it in this device called the polymerase chain reaction, which is a way to amplify the virus. So the virus, this particular virus, has RNA. And so what you're trying to get on your swab is a sample of RNA that you can amplify in the device, and then you get a positive test. So it is very, very common in respiratory illnesses for people to have virus in their airway for many weeks, viral shedding. That does not equate to being infectious, and it also does not correlate to symptoms. So there are many people who get influenza and they're sick for 10 days, and 20 days later, they're still flu positive, but they're asymptomatic. Okay, so we don't know if that person who's positive for 30, I think we had a patient who was positive for like 30 some days here, and many studies have also reported the same. And we don't know if that person's infectious. Okay, so the question is that person who's testing positive for 3 weeks still infectious? We don't know the answer. The answer is probably not, but that's making assumptions based on what we know about other respiratory pathogens. So that's a little bit of a, that's not surprising to see in a viral infection, especially with the technology. The PCR technology is incredible. They can literally like pick up like one RNA particle and amplify it, and that would be a positive test. So that may just be viral debris like left over in your respiratory tract. Hopefully that makes sense. I know that's not a great answer, but there are people that are testing positive for a very, very, very long time. And you say something about asymptomatic people, that would apply in that case too. The asymptomatic person thing is another conversation that's probably worth noting, especially because the WHO just kind of stuck their foot in their mouth again the other day. I don't know if you picked up on this, but they made this comment that asymptomatic spread is far less prevalent than we thought, or something to that extent. It was very interesting. They were actually referring to a study that was looking at contact tracing. And when you're doing contact tracing, you can contact tracing is when somebody tests positive and then you try to find everybody they've been in contact with, because that's how you deal with epidemics. That's how you shut down epidemics. If you have a bunch of people that don't have symptoms, then you are not going to find them in contact tracing, for one, and that's what they were referring to. It is well documented. I want to be very clear on this. Well documented in multiple studies going all the way back to the original China series, and has been replicated multiple times. There is a lot of asymptomatic people that are spreading the virus. So the WHO, I don't know if you guys picked up on the news articles, but that was confusing. Don't be confused. Asymptomatic people are absolutely spreading the virus, which is another reason to be super vigilant about distance, physical distance, and hand hygiene and or masking, because those things are effective. So hopefully, is that adequate? Did that answer that question? Okay, so Al, is that my dad? I think it's my dad. So he says the CDC has forecast that eventually 60% of the U.S. population could become infected. I think that's probably a very accurate number, and it could be much higher. It's a little bit, that's a dynamic variable. It's hard to pin that one down, because if we get a vaccine, then we could interrupt that natural history. If left unmitigated, it's very likely, just based on what we've seen so far, if we did nothing and we don't get a vaccine or a therapy and we don't do lockdown, I mean, like, lockdowns are not, if we don't get a vaccine and we don't get a quote unquote herd immunity, wait, let me say that again. If we don't get a vaccine, then we have to wait for herd immunity. And the estimated number to develop a community herd immunity for the SARS-CoV-2 virus is probably on the order of 60 to 80% of our population needs to be immune in order to have protective herd immunity. So if you left it unmitigated, absolutely 60% of the population will get this virus. If we can mitigate that, we can perhaps lessen that. But it could be much higher than, it could be, this virus is here to stay. I mean, this one is going to infect a real majority of the population, whether or not they become symptomatic. Many of us will be exposed to this virus. And if you were able to test all of us 10 years from now, most of us would have shown exposure to this virus. Next question. Does anyone have information from the state about rolling back into phase 1? That I'm going to defer, okay, because that's a great question. Here's my beef right now with what's going on from the federal level all the way down. No one's really talking about the plan. What if this happens, then this happens? So if all of a sudden we get 100 cases in Union County overnight, right? What is our threshold to go back into phase 1? The recommendations are out there. The CDC has some good recommendations, and then there's actually a group called the Center for Infectious Disease group out of the University of Minnesota called CIDRAP. They have a lot of really good publications about some of these things. And I think I would really, really like our government and our healthcare, public health leaders to start to give us some idea of what to do if this happens or that happens. What do we do when all of our hospital beds fill up? What do we do when our ICU fills up? What do we do when we get back on the exponential curve? For example, watch Arizona. Okay, Arizona. I'm very worried about Arizona, partially because I have a lot of friends that work in that epicenter, but they're at a place right now, data-wise, where their hospitals are pretty full, and they're on an exponential curve in terms of new positive cases. That's a bad combination, and it should be very clear. It should have been very clear a long time ago during the reopening process that everybody's got a plan for when you get that sort of combination of statistics. Like if we have an exponential case rising and our hospitals are full, okay, let's go back to lockdown. That's how this is done. And I just don't really see a lot of that if this, then this type of planning going on. And that's unfortunate. So that's something to watch very closely, because as different states get to those points and start to get overwhelmed, then we'll probably see a little bit more vigilance in terms of having contingency planning. But I don't know how to get the state, what the state's thinking about. Oregon's doing pretty well actually overall. Same with California. LA is not looking hot, but the Bay Area is looking good, and therefore, and also on the other side of me is Reno. So we're very vulnerable here, just like you guys are, but we may be more so because we have metropolitan areas abounding around us. We have the Sacramento. We have the Bay Area. I feel like a third of the Bay Area comes up here every weekend. And I mean, it is insane. We have about 25,000 people here, I think-ish, on the south shore of Tahoe. And on New Year's Eve, there's like 130,000 people in town. It's just absolutely astronomical, like the volume fluctuations that we see just on the weekends and on the holidays. So we're very vulnerable. We also have Reno on the other side, which is full of casinos, and they are open, okay? I just took care of a patient yesterday who was hanging out in the casinos all week and now has a cough and a fever. Nevada has been pretty aggressive about opening some of these things. So yeah, I don't know. I'm very interested to see what we learn from our first sort of resurgences, the first, as the clusters start to come back, we'll learn how to make some plans to roll back, go back and forth and back and forth. And it's going to be a dance. For a long time, it's going to be a dance, and we're going to learn the dance moves, but it's going to be a little bit clunky. We're going to have to all be willing to kind of roll back and maybe go back and shelter in place, and we may have to shut down the restaurants again. It just depends on where you are. Okay, how much can we trust the test results? False negative. Thank you. That is such a good question. I'm glad that you brought that up because that's an important concept. Now, this is a very interesting. So we talked a little bit just a second ago about how the test works, right? You're just trying to identify the viral RNA. You're not actually identifying viable virus. You're just trying to get the DNA, or in this case, it's RNA, but just, their genetics. You're just trying to get their genes. So when you get infected with a respiratory pathogen, like a virus, like influenza, there's RSV, there's human metapneumovirus, there's rhinovirus, enterovirus, echovirus, adenovirus. There are so many viruses. And one of my favorite things about this pandemic, I'm trying to be positive about all this, but one of the things that I do think is very positive is that our society is really learning about viruses. And that's very important because viruses are all around us. And I think that there's a pretty stark lack of just sort of health literacy in our country in terms of just basic biology and like infectious disease transmission. For example, with all the tricks and tips that we learned from this pandemic, we may be able to markedly reduce the morbidity and mortality from seasonal influenza going forward. If people just would stop coughing on each other and like wash their hands every once in a while. So these kinds of things are important. So let's go back to this test. When you get infected with the virus invades your cells in your airway, typically. We'll just talk about the respiratory viruses now. But there are also gastrointestinal viruses and tons of viruses. The virus needs a cell to get inside to replicate. They have a singular goal in life, is to get inside a host cell and replicate themselves. That's all they're designed to do. They don't even have like a nucleus. They're not even truly organisms. They're just a piece of a genetic material that wants to copy itself. So when you get the virus in your airway, you breathe it in or whatever, it gets into your airway, and then it invades the cells and it starts to replicate very, very, very quickly. Like it'll replicate, and then it can, over the first couple of days, the viral load, so to speak, they call it the viral load, rapidly increases. So if you could test someone in those first couple of days, you are likely to have a very accurate test because the PCR test is very accurate when it is positive. Okay, when it's positive, it's pretty much positive. That's a very accurate test. But when it's negative is what you're talking about. You're talking about false negatives, people who are infected who have a negative test. And it's a problem because as the virus starts to replicate over the first 5 to 7 days, you get this massive spike in viral load. And at that time, the test is actually pretty accurate. But the problem is that the clinical illness is delayed. So the first 5 to 7 days, you're replicating virus, you have lots of viral load, but you don't get sick until, say 8 or 9 or 10 days into the illness. And by that time, the viral load has actually started to drop off. So no one's going to come in when they're not having any symptoms to get a test. They're going to be coming in when they're actually developing a cough and a fever, which may be after that peak viral load. And so you may be on the downswing, so you may actually not actually get the virus, or the patient may not be replicating in that sort of replicative cycle of the virus's life. So I hope that makes sense. The bottom line is in the first week of infection, and many people don't have symptoms in the first week, the test is pretty accurate. You're only going to have about 1 in 10 false negatives, which is not great, but it's not so bad. The second week, it's more like 70%. So that's 1 in 3 are false negatives. Yeah, that's a problem. And that is a big problem that's not totally surmountable because of what I just described. Physiology is not working in our favor. So by week 2, when we actually test most of these patients, there is a very high false negative rate, and that's about 1 in 3, unfortunately. So I hope that answers your question. We have to be very conscientious of this on the medicine side and on the public health side to try to account for these false negatives. Because if somebody gets tested in the 3rd week of their illness, it's like 50-50. So we're kind of incorporating that into our clinical assessment of these patients. A lot of patients that we've had and that I've had personally are coming in with very, very convincing clinical syndrome of coronavirus illness, and they have a negative test. So we still have to isolate them. We still have to sort of pretend that they have it, and we still have to be careful about that. And hopefully we'll be able to start retesting people with like antibodies and stuff. How much do we trust the test? Yeah, so lots of false negatives, be aware. But in general, it's a pretty decent test. From Mark, 60% of the population in Wallowa becomes infected and the mortality rate in Oregon is 3%. Does that lead to the conclusion that 126 of our friends and neighbors will die from COVID? Okay, thank you, Mark. Let's talk about the fatality rate for 1 second. All right, this is a big contentious issue. It has been published and was published early on from China data and even from later from some Italy series and then also even some New York data that the mortality rate was around 3%. All right. That is a number that really needs to be contextualized because that is among the people who are sick enough to seek testing. And also that was early in the pandemic. So as time has gone on, we have tested many, many, many more people, many people who don't have symptoms, many people who are not in the hospital, many people that don't have a cough or a fever, and people who are very well. And so now we have more sort of prevalence data that says that the mortality rate overall for the entire society is going to be far less than 3%. Okay, that's very important. It's going to be probably somewhere on the order of 0.5%. Okay, and by comparison, influenza is often cited as having a 0.1% mortality rate. So to your question, it's not quite as simple as saying 60% of the population will get infected. That's X number of people and 3% of them will die. Probably less than 1% of them will die. But some will get sick and some will be in the hospital and some will get critically ill and some will survive those illnesses. But so death is not everything, but I don't want people to think that 3% of the overall denominator of people who are infected will die. That's terrifying, and that's not the case. So be clear on that. It's still a pretty nasty bug. Okay. This is not flu. Okay. That's an important concept. This is a nasty one. And we want to be getting it. And we want to really protect our vulnerable, family members and loved ones and community members, but probably around 0.5% will be the overall case fatality rate. When you're reading the news and you're hearing about mortality and case fatality and how dangerous is this thing, just be aware that these numbers that people throw around are pretty nuanced and they're used and interpreted very incorrectly in the lay public and in the lay press. So just be patient. We're not going to know the overall case fatality rate until we're at the end of this thing, unfortunately, but it's definitely less than 3%. And I think that most people that get the virus will be okay. So I think it is your comment here, Mark, is true. A lot of people are going to get this, and a couple people are going to get real sick, and a couple people are going to die. And we all are going to know these people. I've already had a half a dozen friends and colleagues. Unfortunately, healthcare workers are getting sick, particularly in these really, really hot spots. But I've had friends and colleagues die, people that I trained with. And I know many, many doctors who have gotten this disease and done fine. They do fine. But unfortunately, eventually, like I said earlier, eventually we're all going to know somebody that is close to us that has gotten sick. So that's unfortunate, but it's not going to be 3% of us, thank goodness. Finding resilience when our county commissioners feel we are expendable is tough. Yeah, gosh, I know. I just encourage you to, I feel this too. This is Megan, Kathy. I feel this too. As a doctor, it's been very, very, very weird. It's been very stressful, the most stressful period in my career. Information overload, trying to keep up, feeling a duty to just save the world almost, and being terrified that we're going to get overrun, or especially early on, you're watching what's happening in New York. I had colleagues working in New York. It's horrifying. In that, at the beginning of all this, we were sort of like the healthcare heroes, and that was like incredibly inspiring and just so heartfelt. And then we sort of morphed into sort of like the enemy, and sort of the purpose. So it's been a roller coaster, and I feel you. The division between the line between how different people are sort of like buying into the efforts to mitigate the virus transmission is really, it's really tough. It's very emotional. What I would say is just avoid the noise. This is not a political issue. This is not an ideological issue. This is a biological issue. And so just try to get the best information you can get from reliable sources and just sort of ignore anybody who has any sort of like emotion or attachment to it, because this is a really pragmatic problem that we need to solve. This is not something that we can, rant about and kind of politicize and polarize. I don't think that anybody thinks that anyone's expendable. I like to give the benefit of the doubt to those making decisions in the very hard decisions being made by people right now. I don't agree with some of them, but I do extend a little bit of, understanding that there is no real right way to manage this, and there will be bad outcomes, and it's going to hurt our economy, and it's going to hurt our families and our communities. But I think everybody's trying to do their best. That may be a little bit too charitable. Lately, I've been starting to wonder, but I'm trying to be charitable. Okay, so be resilient. We'll get through this. There's a way. The next question is, if you test positive, what are the signs that you need to go to the hospital? Okay, great question. I have this conversation every single day. Even if you don't test positive, because if you're sick and you have a fever and you're doing okay, you may get a test, you may seek out a test, but even if you aren't able to get a test or don't really want to get a test and you just assume that you have coronavirus, I encourage testing, but some people, when you're sick, you just stay home. And nowadays there's more testing capacity, but before we didn't really have that many tests. And so we were like, hey, if you're fine, if you're feeling okay, just stay home. We don't need to do the test, or the other thing is, bringing an infected patient out to the hospital and do a test, or to a testing site. It kind of exposes other healthcare workers. We have to stick a swab in your nose, and it burns that PPE that we're trying desperately to conserve. And so sometimes you won't get the test. That's a digression. To your question, what are the signs that you need to go to the hospital? This is largely about breathing. If you are having trouble breathing, it's one thing to have a cough. I tell patients all the time, a cough is different than shortness of breath. Like if you have a cough, coughs are annoying. But most of the time when you have a cough, you're not really struggling to breathe. I think we can all appreciate that. We've gotten the virus, we get a cough, we get a bronchitis, and it's like coughing a bunch, annoying, but we're breathing okay. We're not struggling to breathe. We don't have significant shortness of breath with any form of exertion, for example. So what I would say is that if you start struggling to breathe, if you feel like you're really huffing and puffing and breathing faster and deeper just at rest, or if you have exertion, so if you feel like you're short of breath more so than you normally would with exertion, those are the kinds of things that I want to see. Like the breathing problem, and you've heard in the news, this disease is largely about respiratory failure and pneumonia and oxygen problems. And so if you're having trouble breathing, somebody needs to check your oxygen. And we need to see you, we need to do a chest x-ray, we need to make sure that your vital signs look good. So focus first and foremost on your breathing, okay? The other thing is kind of some basic stuff. When you feel really terrible and you're like, I don't want to eat, I don't want to drink, I'm not sleeping well, I'm not taking in enough fluids, I'm not able to keep myself hydrated. There is a lot of diarrhea and vomiting associated with this disease. This is actually, hopefully, I'm not sure if you guys have heard this one, but in certain series, 30+% of patients are presenting with coronavirus with only GI manifestations like diarrhea and vomiting, not like pneumonias and respiratory symptoms. And that seems a little bit confusing, but that's actually very normal, especially for coronaviruses. Many of the coronaviruses cause both respiratory symptoms, and they can occasionally cause diarrhea and stuff. Like the kids get all these coronaviruses. There's 4 of them that circulate endemically and mostly in the pediatric population. They'll get diarrhea and vomiting, and it'll that it could be a coronavirus. The same virus could also cause a cough and a sore throat. So some people can get really dehydrated, and if you're not able to keep up with your hydration, then that's another time to go to the hospital. And then lastly, just feeling miserable. Like if you're feeling miserable and weak and energy deplete, these could be signs of low blood pressure and things like this. And if you're just feeling terrible, we need to check you out. But if you're feeling okay, you're breathing okay, and you're keeping your fluids and stuff down, you just want to isolate at home and quarantine and make sure you don't give anybody. Hopefully that answers the question. That's a good question. Why don't some people get symptoms? I wish that someone knew, and I wish I knew. I could kind of wax and wane for a while here in terms of like the innate immune system and immunoadaptive responses that different bodies have, and the influence of comorbidities that predispose people to getting worsened infections. The amount of virus you're initially exposed to is a factor, which goes back to the idea of viral load. And like, so if you get exposed to someone with a very high load, you might be more likely to get symptoms. Whereas if you just get exposed to somebody who has a very low viral load, you might not get symptoms, but you're still carrying the virus. The question of why do some people get sick and why do some people get symptoms and why don't some people get symptoms is pretty complex physiology, but it's actually consistent. It's actually seen in most viral infections. Some people just do well. So, healthy immune systems can knock out most of these viruses. So that's a part of it. Then we're kind of running out of time here. I don't know how strict we are on time, but the next question is, there's a couple more. Let's try to bang these out. What's the typical timeline for contracting the virus, being contagious, showing symptoms, no longer being contagious? Thank you for asking that. Okay, day 0, you get infected. You get exposed to the virus and you get infected on day 0. The median time to the onset of symptoms is 5 days, okay? 98% of people will have developed symptoms by 12 days, I think, okay? So remember, day 0, you get infected with the virus. Day 5, you start to develop symptoms. Being contagious, don't know. Probably extrapolating from what we know from other viruses and what we've observed with this virus, and you may have heard some recommendations like at least 10 days after the onset of the infection or the symptoms, and 3 days after, I'm sorry, at least 10 days from the onset of the infection, so day 0 to day 10, and at least 3 days past having any symptoms whatsoever. So does that make sense? So let's say you get sick, you get infected on day 0, you get a fever on day 6, all right, and you're coughing, day 5, day 6, you start coughing, then you're sick, coughing, fever, not feeling so great. That stage of the illness, you don't actually point out how long am I going to be sick for. That varies substantially, but in other respiratory illnesses, it can average up to 20 days. So it's actually quite a long time. You're usually getting better during that time period, but you're usually symptomatic for a couple of weeks. And then after you're done being symptomatic, you want to be at least 10 days out from the time that you were infected and at least 3 days out from the time that you've had any symptoms whatsoever. That is very, very rough, okay? Basically, we don't really know how long you're going to be contagious. We talk a lot about this with the flu, viral shedding, and people have been documented to give, to be able to infect other people for weeks, and prolonged viral shedding. And it's a pretty complicated issue, but just like in general, 3 or 4 days, like after you're totally better, usually you're not going to be super contagious. There's not a good answer for that. So just, be careful for a good period of time after you're done with the infection, masking and gloving and, staying home, not gloving, I'm sorry, masking and washing your hands and staying home for as long as you can and until you're totally better. Sorry, that was a terrible answer, Susan. Hopefully it's at least digestible to some extent. And then last question here, quick, are asthma patients more vulnerable? Now, that's a really good question because you could expand that question to say anybody with any sort of chronic lung disease of whatsoever or any other comorbidities, are they more vulnerable? The asthma situation is, I would say, so some of the studies definitely, all viral infections seem to have a predilection for causing worse outcomes in patients with lung disease. Okay, that's sort of a general rule of thumb, and asthma is one of those chronic lung disease, COPD, things like this. The thing is if you are asthmatic, and so the #1 cause of asthma exacerbations are viral infections. All right, so a lot of the time when you get an exacerbation, it's from an infectious agent like a virus. And so what happens when you have asthma, if you get the coronavirus and you get a pulmonary injury and like a pneumonia, it's likely to trigger your asthma. So you kind of have two things going there in terms of like, okay, we have this infection, but we also have this asthma exacerbation. So then we have to treat the asthma with the asthma treatment. And the reality is that we do that pretty well most of the time. People who get like influenza and get asthma exacerbations, you know, concomitantly, you know, we can manage that pretty well in most patients. So I wouldn't, you know, certainly having a chronic lung disease puts you at a little bit more risk, but I wouldn't worry about it too much. You know, I would just maintain, you want to be on your maintenance therapy. You want to make sure you're taking your medications. You want to take extra steps to be careful about not triggering your asthma and staying away from sick people. But I would just a little bit, it complicates things a little bit, but not to the extent that it's something to worry about. Hopefully that's a reasonable answer. All right, so that's all we have for questions. I think we're kind of getting out of time. Rich, you want to jump in here?
Well, thank you very much is what I want to say. And I want to tell everybody in the community that I think there was a lot of good information there. I'd like to stress that thing about we can all set examples by our own concern, and attending this means that you're concerned. So I think we can set an example in the community and do our stuff out there and keep track of things. And you know, any of your sister communities in terms of not only you're having a relationship with Wallowa County, but being basically tourist-dependent economies. And so, as you have information there, if you shoot me something, I'll spread it out.
Rich,
Are you up for that?
Unfortunately, Rich, I lost a lot of that. I think you were saying, hey, we're both super vulnerable, and like if you learn anything, you tell me, and if I learn anything, I'll tell you.
Yeah, we'll keep track of you, but you have, you know, you're kind of Wallowa County on steroids there, right?
Yes, well
Okay.
put. That's exactly right. And I will keep an eye on things. And I'm watching, you know, I wish someday I'll live there. Hopefully you guys will welcome me.
Well, the next time you're in town, stop in and we'll get a small group together to continue the conversation. How's that?
I would love that. I may actually be coming up there, depending on how Union County, if Union County blows up, I may not, but I might be swinging up there next month.
Okay, with that, I'm going to ask everybody to give a big thank you to Clay, and thank you for attending today.
Thank you, everybody. Remember, wash your hands and be vigilant, but don't be scared. Just kind of be patient. It's going to be a bit of a long haul. So
Clay, it's Meg. We're not going to see you for a while. There's 240 cases in Union County.
Yeah.
So be safe, friend.
Okay, guys. Yeah, be safe, and we'll talk again. I'm happy to do this anytime that works for you.
Rich, may I make a comment to you? So everybody else can hear. I think at some point we ought to have one of these meetings on the new normal, because there's a lot of stuff that's coming out of this that is going to affect how we invest our money, how we go about our way of life, and things like that. And I think that conversation should be had sooner than later.
Thank you. I think that's a good.